So it's my pleasure to introduce Dr. Beni Negalur. She is a consultant diabetologist and physician from Dr. Negalur's Diabetic Specialty Center. As well as she's a diabetologist at Jupiter Hospital, Thane. She is visiting faculty for diabetology fellowship program at D.Y. Patil University, Mumbai. She is teaching faculty for Public Health Foundation of India, as well as fellowship of obesity from MUHS, Nashik. She is also organizing chairperson for annual conference, that is Women and Diabetes, from last 3 years, almost 2017, 18, and 19. So over to you, madam.
Thank you so much, Dr. Dasmani. And I must tell that very talented couple, Dr. Manoj and my very, very good friend, Dr. Purvi, you're doing an excellent job by saluting the discovery of insulin and saving the lives of so many patients by having this session today. And you've heard all through this month that Leonard Thompson was the first recipient of Banting's insulin. But let me tell you, since I'm the only woman speaker in this and I'm speaking for women, that it was Elizabeth Hughes who was the first girl recipient of type 1 diabetes. She got type 1 at the age of 11. She was the daughter of the governor of New York, and she was the first lady recipient of Banting's insulin. And remember that she lived up to the age of 72, which is really great for a type 1 patient after taking 3 or 4 insulin injections per day. So that's an inspiration to everybody else. Let's see what is the effective use of insulin in Indian women. Thanks for this topic. This is very close to my heart because I deal with women and diabetes. You can see the numbers increasing, the prevalence of diabetes here, both in men and women, and it's going to be higher and higher in the years to come. But if you compare the men and women, they are comparable. For every 9 women, there is 1 woman with diabetes. And we know that we are seeing younger and younger diabetics, and the survival age is also going up because of early detection and improved diabetes management. And so the area under the curve of the number of diabetics is increasing and will increase in the years to come. You will see what is happening in India. This depicts the prevalence of diabetes per 100 women in their late reproductive ages between the years 35 to 49. And you see Kerala, Andhra Pradesh, Mizoram have the highest prevalence, 14.9, etc. And you see all the shades of red and orange, and you will see Rajasthan having the lowest prevalence, 6.4. Women are different from men besides the XX chromosome, which gives rise to the estrogen and progesterone, which has its effect on all the tissues of the body and especially on the reproductive organs. There's also a gender issue which is economic, behavioral, environmental, lifestyle, which also contribute to the development of germ cells, the fetal programming, the newborn, puberty, reproductive age, aging, and the manifestation of diabetes, complications, and comorbidities. And women show more dramatic changes in hormones and body due to the reproductive factors during lifestyle. And you can see here the physiological differences. Men have increased food intake, increased energy expenditure, increased visceral fat, increased liver fat, increased muscle mass, low adiponectin and leptin, and women on the other side have the opposite of this. If you look at the pathological sex differences, you will see that men have an increased fasting glucose incidence, whereas women have increased glucose tolerance incidence. Men have increased diabetes incidence at an earlier age. They have an increased fatty liver, and women have an increased BMI, increased glucose tolerance, and increased obesity, but not so much of a fatty liver. They have increased depression, increased androgens, increased PCOS, and so they are different. What is the what is it with insulin and estrogen? We know that estrogen is very important because it gives a positive effect on the metabolism, especially it optimizes the insulin activity. And premenopausal women produce estrogen, which actually controls the insulin resistance. And if you see this graph here, you will see that in the pathophysiological mechanism with sexual dimorphism, you will see that women are more insulin sensitive than men, but this sensitivity only remains when they are normal glucose tolerant. Once they have abnormal glucose tolerance, then men have more of impaired fasting glucose and women have more of impaired glucose tolerance regardless of their ethnicity. And if you look at the pathophysiology of diabetes, you will find that abdominal visceral adipose tissue is more strongly associated with insulin resistance in women than in men. And obesity and metabolic dysfunction in women decreases the inherent sex hormone protection from cardiovascular disease, to which the women have a higher risk than the men. If you look at the menstrual cycle, this is also one of the physiological mechanisms related to insulin, and that's why I put this slide over here. The estrogen progesterone which surge during menstruation also affect your blood glucose levels. And in some women who have type 1 diabetes, the hormonal changes that come with menstruation can cause changes in the blood glucose level. This is what happens in normal pregnancy. Somewhere between the 24 to 28 weeks, the insulin requirements increase markedly, right up to 36 weeks, and then they come down after that, giving rise to women who cannot manage this or who have less amount of insulin, a condition we know of GDM. Insulin is the preferred drug of choice in GDM. Although 70 to 80% respond to medical nutrition therapy, you have to combine it when insulin requirements increase. And some of the women can also be put on an insulin pump or on a pen or syringe, whatever is affordable to the patient. In pre-gestational diabetes, we know that the levels of HbA1c have to be around 6 to 6.5. You need to omit all the glucose-lowering oral agents and put them on insulin. I'll just tell you subsequently which are the good insulins to be used in hyperglycemia in pregnancy. When do we initiate insulin? You see the different guidelines here. ECOG says that when fasting goes above 95, 1 hour levels go above 140 and 2 hour levels go above 120. In addition to nutrition therapy, you have to start insulin. IDF wavers a little with the fasting. So they say any fasting level of more than 90, along with nutrition, you have to initiate insulin. Whereas DIPSI guidelines, which in the Indian scenario, we follow this. Insulin is often added to nutrition therapy when the fasting glucose levels are more than 90 and 1.5 hour postprandial glucose are more than 120 after 2 weeks of medical nutrition therapy. Mind you, we should not try medical nutrition therapy only for more than 2 weeks, but it has to be combined with insulin therapy and continued throughout pregnancy. What is the choice of insulin regimen? We normally give short-acting insulin. A prandial insulin is the correct way to start. It depends, you can give once a day or twice a day, depending on the postprandial excursions. Start with a small dose. 4 units is enough, but you can even go on along with medical nutrition therapy at a lower dose. You can give 3 units and 2 units, but multiple doses, depending on the prandial excursions, are good enough and they give an excellent control. But if the fasting plasma glucose is more than 110, then you have to give a basal. You can give a basal insulin or an intermediate acting insulin at bedtime. In those patients where basal bolus regimen is not convenient for the patient, you can give a premix regimen, keeping in mind the limitation of titration with a premix insulin. What is the choice of insulin? Which one is favorable? ECOG says insulin analogues have been used in pregnancy and do not cross the placenta. IDF says rapid-acting analogues, Lispro and Aspart, have been found to be safe in pregnancy. And the usual recommendation is to use NPH or Detamir as basal insulin, but premix insulin are convenient alternatives, but they lack the flexibility, and therefore you have to be a little careful. NICE says that Aspart, Lipro have an advantage, but DIPSI guidelines says that it's ideal to use human insulin. They are least immunogenic. Rapid-acting insulin analog, Aspart and Lispro, have been found to be safe and effective, and they give an optimal control of the postprandial glucose during pregnancy. This is all the data that has come before 2015. They divided this into category B and C. You will see that all the faster acting insulins, whether they are conventional insulins or analogs, Aspart, Lispro, and the long-acting insulins, Detamir, NPH, and the mixed insulin are in category B. The only insulins that have not got approval are insulin glulycine, which is a rapid and should not be used, and insulin degludec has not yet got the FDA approval. It is still in category C. Insulin glargine, there is a little, it's a little shaky. Although it comes in category B, they are now changing the views after 2015, and they are saying that if the woman is already on glargine and is doing well, then they can continue glargine to weigh the benefits of between and suboptimal glucose control and the insulin that is used. This is the RCT that was done in 2014 by Hod and al. And this was the first large RCT to prospectively investigate long-acting Detamir in pregnant women with type 1 diabetes. And they found that Detamir was associated with longer-term pregnancy. It also showed a better PPG fasting control and similar hypoglycemic events as that of NPH. And that is why it was approved. It is a good drug to give when the Detamir is required in large doses. You can also divide it twice a day, morning and evening. This is the RCT that was done in 2010 by Heller and all, and this has shown that rapid-acting analogs are also useful in pregnant women with type 1 diabetes. Here, the study was done in type 1 diabetes. Insulin Aspart was compared to human insulin with NPH, of course. They not only evaluated the maternal hypoglycemia control and safety, they also included the perinatal outcomes, and they found that insulin Aspart had a better PPG control, and compared to human insulin, both had similarities in maternal and neonatal outcomes. So we have now RCTs to prove that rapid-acting analogs are safe in pregnancy, and also Detamir is safe in pregnancy. We know that postpartum glucose management in pregestational diabetes, you have to reduce the insulin 30% of the pre-delivery doses for the first 3 to 4 days, or the rule of the thumb is 30% of pre-delivery insulin dose or 60% of the pre-pregnant insulin dose. And then depending on the monitoring, you can increase or optimize the sugars control. This is the changes in weight in pregnancy and the insulin requirements. You will see that from 0 to 9 weeks, the insulin requirements increase. 9 to 14 weeks, they actually decrease. They go down further. Requirements go down between 14 to 16 weeks. And then from 16 to 37 weeks, it actually doubles the requirements. And 37 to 40 weeks, they come down further, and immediately postpartum, they can drop to half the pre-pregnancy needs, which has to be kept in mind when we start treating our patients of hyperglycemia in pregnancy. This is a physiological graph to show the insulin requirements in men and women. You see somewhere at puberty, between the age of 10 and 14 in girls, there is an insulin surge or requirement increase. If they are type 1 diabetic, you have to step up the doses of insulin in this phase, after which the insulin requirement come down a little. In boys, on the other hand, the stepping up of the dose should be between say 13 to 16 years of age, and it remains higher than the girls. This is specifically applicable to those taking insulin at a younger age. Type 1 diabetes, as we know, in women, insulin is the therapy of choice, and it can be given in vials, injection pens, or even in pumps. This is another area where we have to give insulin. Young diabetics now are different from the older diabetics because they have lesser beta cell mass. They're usually lean. They have more comorbidities. They have increased risk of cardiovascular disease, and they are insulin requiring very early in their duration of diabetes compared to the older patients above the age of 40 and the onset after the age of 40, whose general pattern we all know of. Therefore, we have to keep these young individuals in mind because of the complications that can happen and starting insulin very early. Estrogen, progesterone in women affect how the cells respond to insulin. Therefore, after menopause, there's a change in the hormone levels that can trigger the fluctuations in the blood sugar level, and that can also give rise to glucose variability in postmenopausal women if they are on insulin. By the time they are menopausal, you see they are already on 1, 2, or maybe 3 drugs. This is the time when you have to consider giving insulin therapy. They might also be on hormone replacement therapy. And also this is the time for fluctuation, perimenopausal, postmenopausal, and therefore the insulin requirement changes. In any kind of infection in women, of course, also in men, this is nothing different in women. You have to put them on insulin, especially if they are admitted or in the ICU. And especially you saw now in the COVID era, in the first wave and the second wave, the third wave, most of them were asymptomatic and the admissions were few. But in the first and second wave, they were quite morbid patients. Hospitalization was higher. And also they were put on high dose steroids, which has totally disrupted the glucose control. And women are no exception to this. So they required insulin at that time. And any infection when they're hospitalized, those women who are on OHA have to be put on insulin. There's another aspect now of women, which is different in men. You see that in South Asian countries, the low literacy traditions such as consanguineous marriages, urbanization, they multiply the risk of diabetes. And there are so many cultural barriers which actually prevent the adoption of a healthy lifestyle and medications, especially in insulin requiring women. And these are the risk factors because an illiteracy makes a woman the slave of the family. She does not have the confidence to take decision on the treatment and make her totally dependent on others on medication intake, more so if they are on insulin. And you can see the board here held by the child. Over 250 million women in Asia are illiterate. There's also a gender equality. The belief that girls are born to serve and boys to earn and rule prevails in most of the South Asian countries. And since I have to speak on Indian diabetics, I think this applies here. In a limited income family, the boy is given better food and provided education. The girl gets poor nourishment and is made to do the household chores from a very young age. She's dependent on the male members of the family. And example, a woman cannot receive needed health care because norms in a community prevent her from traveling alone to a clinic, even during pregnancy. And also if she is on insulin. So you can imagine the socio-economic factors which actually disadvantage a woman from getting proper care and treatment because of their accessibility to insulin, especially during pregnancy, and affordability also to the medications that are required in diabetic women. So in summary, diabetes in women presents differently due to the reproductive hormone profile, fat distribution, and other metabolic changes, including the lifestyle, the socioeconomic, and the psychosocial issues. And therefore, suboptimal diabetes care during puberty and adolescence can affect the fertility, while inadequate diabetes care during pregnancy can have adverse fetal and maternal outcomes, and therefore give rise to a future generation which is already compromised in their metabolism. management of diabetes accordingly becomes different in women and men. And healthcare professionals should appreciate the differences in women and men in terms of diagnosis, in management, in insulin requiring women, and also on their follow-up. Thank you. Thank you very much.
Thank you. Thank you so much, ma'am, for focusing on the effective use of insulin in Indian women. There are some questions. When to start long-acting insulin in pregnancy?
Normally, we start with a short-acting insulin along with nutrition therapy. When you feel that the postprandial excursions are getting out of hand and the fasting is going up, you look at the fasting glucose. If the fasting is going up, then you start a long-acting insulin in addition to the rapid insulins that you have to give for the postprandial excursions. So you need to monitor the fasting and also the postprandial in these pregnant ladies. And the fasting in pregnancy has to be pretty low. And the targets have to be less than 95 fasting. So that's the time when you give a postprandial. And that's the time you give basal insulin. And if the basal is too high, you can also divide it into two.
Okay. We had a discussion about use of metformin in pregnancy. Ma'am, what about your ways, Miss? How you see about metformin use in pregnancy?
See, there are many guidelines. Indian guidelines also say that you can give metformin in pregnancy after 20 weeks. This is very important, the last 3 words, after 20 weeks of pregnancy. Because the MITI trial and also the MIG trials and the MIG follow-up trials have shown that metformin is relatively safe. But you see, the MITI trial that came out 2 years ago have shown small for gestational age babies. That was the only hitch. Otherwise, it has shown benefit. Metformin has done well in the pregnant ladies. And so if you give metformin too early in pregnancy, before 20 weeks, I think there will be a problem. Also, metformin is not to be given when they have other maternal complications like preeclampsia, like say hydramnios and hypertension. And I think metformin should not be given. The only place where I give metformin is if the woman has PCOS and I continue it for the first 3 months and then I withdraw. But in the 3rd trimester, if the woman can manage with nutrition therapy and they are just borderline higher, then you can afford to give metformin to these women to decrease the glycemic variability. And secondly, if the woman is obese, in obese women, metformin does much better, but it should always be along with insulin in small doses. I give insulin even 2-2-2. I don't go to 4 units. I give 2-2-2, then I increase and then I may use metformin in obese people.
Thank you. Thank you so much, ma'am, for focusing on the use of insulin in Indian women.